item and we're quorate.
Fabulous. Thank you, Jason. Thank you very much indeed, Jason. Thank you for joining us. Okay, I'm going to count us down, Gina, if I may, then to start the meeting. Okay, welcome everybody to the last meeting. It saddens me to say that, but as times move on, to the Joint Committee for Clinical Governance Commissioning Groups. But welcome to the Joint Committee. It is the last before we hand over all its responsibilities to the new statutory NHS West Yorkshire Integrated Care Board on the 1st of July. And as chair of this committee over the last 4 or so years, I wish everybody on that care board moving forward all the very best. As usual, members of the public can observe the meeting via the live stream. I'm going to take, first of all, apologies. We have apologies given from Robin Tuddenham, and we've got Leslie Stokey deputising as Director of Finance. So welcome to our meeting today, Leslie. Additional attendees for the West Yorkshire meeting today is the West Yorkshire Healthy Hearts, Dr. Steve Ollerton, Dr. Wajas Tahir, and Peter Waddingham from the Academic Health Science Network. So whether you're joining us or whether you're online at the moment, welcome all of you to that, and we'll catch up with you on your agenda item. Just in terms of domestic arrangements, if I may, this morning for everybody, if we can ask people to mute your microphones when you're not presenting or speaking, please leave your camera on, because I think it's just sheer, I think it's nice to do that. It makes us all part of the meeting. And please use the raise hand function if you'd like to ask a question. If, for example, your raise hand function isn't working, please feel free to wave at me frantically on the screen, or failing that, please do feel free to interject. Okay, moving on then, if I may, to the role of the Joint Committee. Just a reminder for our public members today, the committee is made up of 5 West Yorkshire CCGs, with the North Yorkshire CCG as an associate member. It has delegated powers from West Yorkshire CCGs to make decisions on specific work programmes. And although the committee supports the Health and Care Partnership, it does not represent all partners. It is not the business of the committee to deal with issues in individual places. So just so we're very clear on what the Joint Committee is, I'd read it out every time and have done for the last 4 years, but just make sure we're clear about the role of this committee. I'll move on then, please, to item 9.22, declarations of interest. Yes, Jonathan Webb, please.
Thanks, Chair. Just for clarity, I put it in the chat box, but as I said before, Joe Webster sends apologies today, as does Adam Shepherd from Wakefield CCG.
Right, I appreciate that, Jonathan. I should have picked that up. Thank you very much indeed, Jonathan. Okay, any other apologies that we know of? I should have asked that. Thank you, Jonathan. No?
Not that I'm aware of, Chair, no.
Thank you, Stephen. Okay, moving on then, if I may, declarations of interest. Is there anything in today's agenda where there's interest that you'd like to declare that you haven't already declared? No? Okay, well, I'll take that as a no. Thank you very much indeed, colleagues, today. In terms of questions and deputies, I know we meet virtually and we want to give people an opportunity to ask questions on any agenda item, and members of the public specifically are very important to this committee, and we are invited to send questions to the partnership team and ask them direct committee questions. Stephen, I know we have had a couple of questions. Both Michael and John are on the line today, but at this point, Stephen, if I can hand over to you to take those questions from members of the public, please. Thank you.
Yes, thank you, Chair. As you say, we've got 2 members of the public joining us today to ask questions. Can I go first to Michael Galvin, who's got the first question for us, please?
Yeah, thank you. Thanks for the opportunity to put my question. Slightly concerned that Marie just made a mention in her introductory comments there that this meeting is not to deal with individual complaints. Well, of course, mine is based on an individual complaint, but it's got much wider significance as well. So I'm taking it I can still go ahead with my question.
Yeah, I think you should go ahead, Michael, and let's hear what it is. And if we can't respond to it, we won't. If we can, we will. Is that okay? The
background to it is that I've been treated by Mid Yorkshire Hospitals Trust for a couple of years now for wet macular degeneration of the retina, which involves an injection into the eyeball. For anybody that doesn't know, I didn't know until I contracted this condition. And I've had superb treatment from the nursing staff who administer the treatment and put the needle in. despite my fear. And I was very satisfied with the way things were going. And then on the 10th of March, I had a letter from Mid Yorkshire Hospitals Trust headed Treatment for Ophthalmology. And basically it was a letter, I won't read it all out. It was a letter informing me that from now on, the ophthalmic service for Mid Yorkshire was going to be outsourced to some other agency, which I can't remember. It's Community Health and Eye Care, CHEC. And unless I wished to continue with the NHS treatment, in which case there was a telephone number that I should ring. In other words, there was an opportunity to opt out of the outsourcing scheme and back into the NHS, which I did. And incidentally, in the telephone call, I did express my fury and anger at having received this letter, because I see it as part of a much bigger drift of the NHS to a commercial Americanized system. And the person who received my call, I'm very pleased to say, agreed with me. And I don't know the name, and I wouldn't reveal the name if I did know. But that cheered me. Anyhow, I opted to stay with the NHS. Now, the next time I had my treatment appointment, I did raise this with the nurses who were present, and none of them knew anything about it, nor did any of them heard of ICS. Never heard of it, which I think is all highly significant. They didn't know anything about this outsourcing. And so subsequent to this, or coincident with this, there was a gap in my treatment, which at that point was 8 weeks. It's now more like 3 months. My last treatment was on the 4th of February. I think it was, I haven't got dates, but it was around then. And I interpreted that this gap, unplanned gap, must have something to do with this change in the service. Now, the service had been plain sailing up till that point, and even on that occasion, it was also plain sailing, except that because of the long gap, we decided it would make more sense, and the nurses agreed with me, to have a new baseline, because there'd been an 8-week gap by that point. So I'll stop there, because basically my question is, why was that long gap? Why did it happen? Did it have anything to do with this change in the way the service was being delivered by Mid Yorkshire? I think that the way they were delivering it was great, and the thing about, you know, reducing the waiting time and all that, to me is, well, I don't know. BS. Does anybody know what BS stands for? There's a lot of BS in this letter, and I've tried to, in my question, I've tried to put the lengthy questions in a separate attached document. So I'll stop there and leave it at that.
So thank you for your question, Mr. Galvin. I think James Thomas is just going to respond on behalf of the committee. I can bring James in.
Yeah, thanks, Stephen. Thanks, Mr. Galvin. So my name is James Thomas. I'm a GP. I'm here today as the chair of Bradford District and Craven Clinical Commissioning Group. So thanks for your question, articulated there today, and also I've read your full question as well there. But so first of all, I mean, thank you for highlighting it at the Joint Committee, and I am sorry to hear about the delay in your treatment there that you've described there. As our chair said, the Joint Committee can't go into comment on specific complaints that you've mentioned there, but we can investigate that in terms of that gap you talk about with the 8 weeks with Mid Yorkshire Hospitals Trust. With your permission, we can ask them to do so and investigate that a bit further of the issue there. But I think what you also raise in your question, in the wider points about the use of the independent sector. The delivery of eye services by the independent sector providers was a result of the policy changes back in the 2000s, and the uptake of NHS paid for care in the sector was largely as a result of patient choice, and this is in the pre-pandemic world there. I think in order to support our capacity backlogs currently throughout the pandemic and now, it's been common practice for specialist services to kind of use alternative qualified providers, or sometimes known as AQPs, to provide NHS activity to support the recovery. It's also been common practice for our acute trusts to offer mutual aid to each other during this challenging time.
Sorry, could I stop you
Yep.
for the sake of saving time? I don't think we need a lengthy description of what the situation. I think we know what the situation is. I think, can we take that as all read? We want the answers to the questions, not the fact that you've been doing it, or because I think we could cut all that out just to save you time and, you know, cover more ground.
But I think what I'm saying is, some of our units will choose to work in partnership with other providers for other common eye conditions, like you've described, also cataracts and glaucoma and general ophthalmology, to help with the backlogs there, and therefore use other providers.
With the backlog. You have an amount of staff. Let's make this a dialogue rather than just a litany.
Yep.
You've got a number of staff in West Yorkshire, nurses, doctors, etc. How you deploy them is a question of choice. You're not going to cover the backlog quicker by redeploying them into the private sector.
So I agree that in terms of some of the staff will work across both units or areas and providers there. It's also about estates and having the right estates there as well, and utilising other estates that we've got.
Again, can I stop you? I've had 2 years of experience. I've been in and out for each appointment, even sometimes before the appointment time was due. It's been slick in the extreme.
We acknowledge your frustration. As James has said, we will look into the situation with Mid Yorkshire. It's obviously an issue that upsets you because you've had a really good service prior to that.
Yes.
And now in a situation where you're frustrated simply by the lack of or the change. Staff
I must interrupt you. I'm concerned about the whole drift of the health service, and this is an example of it. And I've experienced it now. And you know, and I hear all. Okay, I won't use the expression, but it is. You know, and I'm glad you've heard the expression at least once, because it is.
Right. Okay. Well, we have heard the expression, and I do acknowledge your frustration, Michael. We're all users of it at the end of the day. And, you know, the people on this call, you know, a lot of them are professionals like James as GPs working in the service day in, day out. And we're all very proud of our NHS. There comes an issue, Michael, where we simply haven't got the capacity, and we're using partner organisations to help us. I think the thing, Michael,
the capacity is the same. The capacity is the same. You're not increasing the capacity by introducing the private sector. You're not increasing the capacity.
Okay, well, I think we would, you know, there's lots of people on this call would possibly beg to differ in some areas, but I think what we're hearing from yourself, Michael, which is important for us to hear, you've got a really good NHS service that you've enjoyed, and you don't want that to change, and you've chosen not to change that.
Absolutely.
The most important thing is for you as an individual to choose that choice. Regarding Mid Yorkshire,
no, that's not the important. That's not the only important thing for me to have that choice. But you know. The National Health Service is much bigger and more important than my choice.
And I don't disagree with you, Michael. I'm not saying that. I think overall, Michael, we've heard the question. The Mid Yorkshire point we will pick up specifically with the hospital, you know, as James has outlined. The wider NHS issue, Michael, it might well be you want to talk to our new system board, a new chief executive. It's as part of the NHS, and I acknowledge what you're saying. Completely. I'm not sure at this committee necessarily, though, we can solve that frustration, Michael, for you personally, and I apologise for that.
Yes, but it's unless committees like this see the thing and object and stand up and be counted, that'll happen. The bulldozer will roll on unless people like you stand up and say no.
Okay, well, I think we've noted your comment, Michael, and I think that's all we can do today. But
okay,
thank you for that. No, I appreciate you saying that, Michael. Thank you. Okay, I'm going to move on to the second question, if I may then. We have a question from John Puntis. Thank you. John, would you like to ask your question?
Yes, thanks very much, Chair. I'll try and be quick. It's two comments on commissioning, really, relating to the closed down summary. One on stroke services and one on cataract surgery. So, making an observation in relation to stroke services. Nationally, now we have a huge problem with large numbers of hospital beds having patients in who are now termed no criteria to reside. So in other words, they're well enough to go home, but they need social support, which is lacking. This has led to very long waits for a bed on the ward for those needing urgent admission from A&E. And that in turn has then had a knock-on effect on ambulance handover times and prevented ambulances responding in a timely fashion to other emergency calls. And it was only recently that the West Yorkshire Association of Acute Trust called on patients not to go to A&E unless they were suffering a genuine life-threatening emergency. Now, some patients experiencing early symptoms of stroke may not immediately be able to put themselves in that category. So my question is, what's been the impact of that advice? Don't go to A&E unless you've got a life-threatening problem. And perhaps more importantly, what's been the impact of ambulance delays on stroke victims in West Yorkshire being treated in stroke units in a timely manner, since clearly speed is of the essence? And is there any data on outcomes in these patients and how that might have been affected? And then the second question in relation to cataracts.
John, should we take the first question first, and then we'll come on to the second question? Yes, would that be helpful?
By all means, yeah. I mean, I don't expect a detailed reply because it's rather a big question, but yes, by all means, take the first one.
Thanks, John. Let's take the first question on stroke services. Again, I'm just going to bring in James Thomas again to answer that, being our clinical lead. Thank you, James.
Mr. Prentice, I know we've met before, so thanks for your questions there. So, I mean, as you know, I mean, stroke presentations can be complex in terms of many factors can affect the kind of outcomes of people there. I think we monitor number of measures as part of the kind of, I don't know if you've heard of the Sentinel Stroke National Audit Programme, this, or otherwise sometimes known as the SNAP data. And that looks at examples from symptoms starting to arriving at the hospital. It looks at the level of disability a person was living with prior to having a stroke. Looks at people who've had long-term conditions prior to having a stroke as well, and then the time from having symptoms started to having a scan, and from getting the treatment. So that SNAP data, the Sentinel Stroke National Audit data, is what we measure ourselves on against kind of national guidance. So there are multiple ways of looking at this. Our most recent SNAP data, and it is from October to December 21, and that's the most recent one we have across West Yorkshire. There shows that the median time from the symptom onset to arriving in the hospital was 3 hours and 14 minutes, compared to our national average, which is 3 hours and 58 minutes. So actually, we do better there. There's 49% of our patients were scanned within an hour of the clock starting, compared to the national average, which is 53.9%. So it's a little bit less than when expected there. So we're always striving to make sure we're improving, to ensure we're having high quality and safe care. But it's not possible to attribute the impact on outcomes of individual factors, like you've brought up in terms of the ambulance handovers or delays in communicate or delays and the communication to the A&E attendances there, although it can be a factor there. Our ambulance handover times compare well with other areas, and the most recent data for the week ending, I think, the 26th of May, showed our ambulance delays over 60 minutes in West Yorkshire were 0.2%. And we were the best performing area in North East Yorkshire by a long way, against our region average, which was of 5.6%. So that was good news there. And as you mentioned about the communication that was sent out, The commission sent out said if you're unwell and unsure which healthcare service you need, call NHS 111. And we know there you'll get a clinical advisor who will direct you to the most appropriate service. And we would expect any suspected stroke patient would result in a 111 directing them to the emergency department there. I hope that could go some way to answering some of your questions there. I know it's not all the detail you want there, but it's what I've got here.
Well, no, thank you. Yes, thank you very much for that. I mean, it sounds like the SNAP data is reassuring, but I guess the question really is what's the trend there, rather than just having a static picture of how you're doing. So you may, I mean, that will become apparent over time.
That's something we monitor, and we will react to and make sure that we are reacting to, because we do want to make sure we've got a high quality, safe service.
Okay, thank you for that. I'll move on quickly then to the other question, which is about commissioning for cataracts. Now, before COVID, the number of cataract operations being done in the private sector but commissioned by the NHS was going up very dramatically in West Yorkshire. And there has been concern about the impact of this movement of cataract surgery out of NHS units. This has been expressed recently in a letter from many ophthalmologists around the country, pointing out that the people who do the work are NHS ophthalmologists who then take on sessions in the private hospitals, which means they're not available to do more complex work in the NHS unit. And also a lot of cataracts being done in the private sector mean that the bread and butter operation for a lot of ophthalmology trainees, which they really need, is then not coming through. So these are concerns that have been raised nationally by ophthalmologists as a professional group. And I wonder if the potential negative effect in West Yorkshire of this movement of cataract surgery out of NHS units into private units has had a negative impact, or if that's even been looked at. Thank you.
James, do you want to come back on that one as well? Because again, it's a clinical question. Thank you.
Yeah, it's me again, Mr. Pontus. So yeah, you're absolutely right. So before COVID, we were aware of this and kind of looking into that, and aware that kind of our dedicated, we have set up a dedicated cataract project group, which is working on some of those issues that you've talked about there. And there is actually, as you said, there's some national kind of guidance, there's some national concern there, and the National Eye Care Recovery and Transformation Programme team is working with its providers and with commissioners and with the independent sector providers and with the Royal College of Ophthalmology to kind of develop a specific guidance to support cataracts contracting. The aim is to ensure that we have eye care services that are clinically and financially sustainable going forward there. And there are a couple of areas that we picked up on there that you've mentioned there. One is about the delivery of training for the next generation of consultant ophthalmologists, and as you said, the bread and butter, and where that's been happening there, and making sure it's equitable delivery across the training for our NHS trainees in all our providers in our NHS cataracts in our NHS cataract surgery there. So we're ensuring that a percentage of independent sector providers will undertake training, have these trainees going forward, so they will get that exposure and experience there as well. And also the other area we looked at is to ensure service users with urgent post-surgery issues and complications that can be advised and managed by the provider's own surgical ophthalmology team, with any requirement and resource from other providers to support this going forward there, so that they get that backup there. So there is a national task and finish group that are looking at the elements you've brought up there, particularly around the cataract pathway. But also it also includes about the kind of medical workforce training issues that arise because of the increasing work in the independent sector and their activity there. I hope that helps.
Do we know, James, when the National Task and Finish Group was actually due to report on that, which might help John with his question?
I don't, but I can find out for you. I know I can speak to Catherine about that and find out when that is.
I think that would really help. I don't know what you feel, John.
No, that would be great, and thanks for the detailed reply, James. Appreciated.
Thank you, John.
Okay, thank you very much indeed, John. Okay, there was no further public questions or colleagues asking questions this morning. So on behalf of myself, to Michael and to John, both of you, thank you very much for your questions this morning. Michael will certainly get back to you in terms of the issue with Mid Yorks, and John will get back to you in terms of the timeline for that that task and finish group on cataract surgery, if that's okay with both of you.
Thank you very much, Marie.
Okay, thank you both of you this morning. Okay, if I can then move on to the rest of the agenda, if I may. The minutes of the meeting held the 3rd of May 2022. In terms of, are there any amendments first? Anybody would like to pick up? No? Okay, are we therefore happy to accept them? Yeah, I see plenty of nods. Okay, thank you very much indeed. Thank you for that, Stephen. Moving on then, Stephen, if I may, to matters arising of the 3rd of May. Can I ask Ian to provide a verbal update, please, Ian, on the harmonisation of commissioning policies, please?
Yeah, thanks very much, Chair. So I think members will recall that over recent months we've been doing work to harmonise commissioning policies that currently CCGs have in preparation for moving towards a single statutory integrated care board arrangement. And last month we brought 19 policies, I think, to this committee, and we agreed those policies through this committee. Since then, we've been working on a second tranche of policies, which some of which are slightly more complicated than the first set. And in developing those policies, we've taken a decision not to bring them here, but to give ourselves a little bit more time post-July when we move to the ICB arrangements to really make sure those are right, do the right engagement with clinicians, do the right engagement with people who are affected across West Yorkshire, make sure that we fully understand the quality and inequality and financial aspects of those changes. So you'll probably see in the legacy report that Stephen's produced that we're recommending that those that work is now going to be handed over to the ICB, who'll develop a work plan to harmonise those policies probably over the first 6 to 12 months of the existence of the ICB. We've also got variation around prescribing policies as well across the 5 CCGs. So this piece of work will wrap those two things up together and hopefully do it in a slightly more considered way that allows us to do the proper engagement with folk across West Yorkshire. So we're not bringing that paper today, but as I've said, we'll have a forward plan around that post July the 1st. Yeah,
thank you for that, Ian. And as I say, it's really important to get that harmonisation right of all policies and procedures moving forward. So thank you for that, Ian. Okay, any comments for Ian? We're happy with that update? At least we know what's happening, which is important moving forward. Thank you, Ian. Okay, I'm going to move on then to the West Yorkshire Healthy Hearts, and it's a pleasure to invite Steve Olafson back. Hi, Steve. Quite a few years ago since your old role. It's lovely to see you. And Dr. Wajas Tahir. I know both of you are going to be talking about the item today, so I'll hand over to Steve and Dr. Wajas Tahir. Thank you.
Yes, morning everybody. It's nice to be. It's not been that long, Marie, but anyway, there we go.
Seems like it, Steve.
Yeah, and I did enjoy the public questions as well. I think always good. This paper should be very quick actually, because we're only updating guidance that first came to you a couple of years ago, really. So there's the diabetes guidance and the cholesterol guidance. And in both cases, there's been changes to the drugs available, really, and the licenses of the drugs. And as we always do, we follow, we follow these with our area prescribing committee and update as appropriate, because we like to make sure our clinicians are up to date as well. Because obviously the guidance was written a few years ago. So the first one is actually the diabetes guidance, which I think Wakas was just going to briefly take you through, and I can do cholesterol and then we can take questions, but it shouldn't take too long. Wakas, do you want to say anything about the diabetes?
I think just in keeping with what I was hearing earlier on the point around harmonisation. So I think this is actually one of the first steps that actually pulls us all together as one guidance that harmonises us across different processes and pathways. So I just wanted to allude to that, what it is. Secondly, just more reassuringly, is that these guidance have already been through various committees, this committee, prescribing committee, and the only reason it's come back is that we've just amended one or two changes just to make it in line with national and international guidance. So we were already on that journey. We've just amended in keeping with the license change around one of the drugs at the time of when we had it in draft. So a few weeks after that, they changed the license, national license change. So we've literally just updated it to make it future-proof as well. Apart from that, I don't think there's much to say on the diabetes guidance. I'm just wondering if colleagues have seen it or if they have any questions. I'm happy to take them back. We have done, if it helps as well, we have done a webinar to healthcare professionals across West Yorkshire, just to really get a taste of how they like it, their feedback on it. At that point, it was just a draft guidance because we were waiting for this committee to get our, dare I say, official sign-off. But the feedback has been very positive. So we've had almost, I think, just under 100 clinicians from across West Yorkshire attend it. Very positive feedback. No sort of concerns that have been raised from the clinical side, and that includes not just GPs but nurses, pharmacists, all allied healthcare professionals. It's like I said, it's been through the prescribing committees as well as clinical boards as well.
Okay, thank you, Dr. Tahir. Okay, so we're being asked then to look at the revised changes to the diabetes guidance. Any questions for Dr. Tahir or Dr. Ollerton? Are we happy with what's been said for the diabetes one? Are we happy with that? Yeah, okay. Thank you for that. We're very happy with that, Dr. Tahir. Thank you very much indeed. Moving back to Steve then in terms of the cholesterol guidance, Steve.
Yeah, so the cholesterol is mainly the addition of some new drugs. I mean, everybody's heard of statins, and our initial guidance was mainly around the statins and switching to high-intensity statins. But since then, there's been an addition of the PCSK9s, and I did notice that was a typo in the paper. Actually, you might want to change that. And inclisiran, which is an injectable form. So these are drugs that are mainly used when patients have been intolerant of statins. And then there's bempedoic acid as well. So these are just additional drugs. So again, bringing us in line with new guidance and adding them into our pathway. So these are being rolled out only in small numbers in primary care. They are quite expensive, but they do have you've had the finances behind them, and certainly in their savings of heart attacks and strokes going forward, they are very useful. So it's just the addition of those new drugs into the guidance. That's okay.
Okay, thank you, Steve. Yeah, Stephen Hardy, please.
Thanks, Chair. Steve, I wonder if you could just clear up something for me. The last time we had a discussion around the Healthy Hearts programme at this committee, it was at the beginning of the rollout of the Bradford project across the county. But then COVID came along and disrupted our planned timetable. Are we now catching up, or are we still behind where we want it to be in terms of prescribing statins to people at risk?
I think we're still very much behind, I'm afraid, Stephen. I think COVID was a bit of a disaster in terms of a lot of these schemes that were going on. But certainly in probably the last year, we've done an awful lot of good work with the primary care networks now. We've got those on board. I've attended a number of primary care networks to show them their data and show where they ought to channel their efforts. And I also think that in the primary care networks, part of the Impact and Investment Fund this year, which is a new national fund, there's a lot of cardiovascular indicators in there. So practices are being encouraged and actually are being paid to bring hypertensive patients in to manage the hypertensives better. So actually, we really have picked up and run with the ball again now. But yeah, the ball wasn't being carried much during COVID, I'll be honest.
Do you mind if I just jump in there as well, Steve, if that's okay? Hi, I'm Pete Waddingham. I'm a programme manager here with the Yorkshire and Humber HSN, and I support this project. And as Steve said, you're absolutely right. There's probably a bigger challenge that we've got now than we had before COVID. There's some useful levers in place. So, for example, there is a financial incentive for practices to prescribe a statin in those with a Q risk of greater than 20%. And I think we'll probably see that's where we'll see some of the impact in the next weeks and months. As Steve said, we've been out there engaging with PCNs to try and drive that. There are large numbers that would would potentially benefit and fit within that category of a greater than 20% Q-risk score. And the statin switches, you know, has been largely successful. You see that in the data at a national level. This region, West Yorkshire, there's some national targets for the prescribing of a high intensity statin, and West Yorkshire are very, very good. Bradford actually are quite high. I think the threshold is 66%. Bradford are up in the 80s, which probably again shows that Bradford were one of the leaders of this piece of work. And actually, I think there's only one CCG in our West Yorkshire patch that are just about on the target, and everyone else is above it. So I think that you can see in the data some really good work around the introduction of high intensity statins, getting people on a statin that are at risk. Yeah, big challenge there, and lots of work to be done.
Thank you for that, Pete. I think it's a really good update. That is that helpful, Stephen?
Yes, it does. Thank you, Chair.
Okay, brilliant. Thank you for that. Okay, so back to Steve, Dr. Steve Ollerton and Dr. Tahir. Are we happy then to look at the revised changes of cholesterol guidance? Are we all happy to approve that? Yep. Okay, so we've approved the diabetes guidance, cholesterol guidance changes. So on behalf of myself, Steve, and Dr. Tahir, thank you both very much indeed. It's lovely to see you again, Steve. Thank you both. Thank you.
Thank you.
Thank you. Bye-bye.
Okay, so I can move on then to item 1422, risk management. Stephen Gregg, can I invite you to present the report, please? Thank you.
Yeah, thanks, Chair. This is the usual risk management report. Appendix 1 identifies a significant risk to delivery of the Joint Committee work plan, which have been reviewed since the last meeting. Controls, assurances and mitigating actions are set out for each risk. There are currently 8 risks scored at 12 or above after mitigation relating to cancer, mental health, learning disability and autism, planned care, urgent emergency care, and 1 risk has been reduced to below 12 since the last meeting and will be removed from the register. On 1st of July, the risks overseen by the Joint Committee will be transferred to the ICB's Corporate Risk Register, and committees covering finance, investment and performance and quality are being established to provide the ICB board with assurance on the arrangements for mitigating and managing all relevant risks, whether that's around performance or quality. So this is the final risk report for the Joint Committee. Joint Committee is asked to review the risks and the actions being taken to mitigate those risks, and note that the risks overseen by the Joint Committee will be transferred to the ICB's Corporate Risk Register. Thank you, Stephen. Comments from colleagues? We're happy to review and note. Are we all happy with that? Excellent. Because it is important we understand how we move away. We don't just forget about what the risks are, bearing in mind the changes in the last 4 years we've made collectively. So it's very reassuring, Stephen, to know the ICB board will actually be picking that up. So thank you, Stephen. Okay, happy with that. Thank you very much, Stephen. I'm now going to move on to item 1522, Joint Committee Close Down Report. Stephen Gregg again, please. Thank you. Yeah, thank you, Chair. Obviously, this is the last meeting of the Joint Committee, first established back in 2017, nearly 5 years ago. The Health and Care Act abolishes CCGs from 1st of July and transfers the functions to the new Integrated Care Board. And as a result, the Joint Committee of CCGs will cease to exist. Since it was established in 2017, the committee has been a key part of the partnership and has pioneered collaborative working on a number of key areas, including Healthy Hearts, which we've already covered. Building on the successful work in Bradford, had a big impact on identifying people with high blood pressure and reducing the risk of heart attacks and strokes. Major piece of work some time ago around stroke, including agreeing a common approach to commissioning hyperacute stroke services. The committee has obviously looked at a range of policies around improving planned care, agreeing commissioning policies which have improved equity and access to services, helped reduce health inequalities, tackled the postcode lottery. Fairly recently, agreed to commission a new care model for assessment and treatment units for people with complex learning disabilities, developing a single system and centre of excellence, and agreed a new approach to commissioning urgent emergency care, aiming to ensure that people who call 111 needing urgent medical attention receive the most appropriate help in the right way. So I think some significant achievements for the Joint Committee, which has in many ways pioneered collaborative working across CCGs, and the governance model for the ICB going forward builds on some of the success of the Joint Committee and the way it's worked, including independent chairs and members of the ICB board and its place-based committees and its West Yorkshire committees, clinical engagement being built into decision making at place and system level, and patient and public involvement through the partnership involvement framework and a new citizens panel which is currently being scoped. The governance arrangements for the work to carry on the work of the Joint Committee are currently being finalised. There's a couple of options that are being looked at in relation to that, one of which is to reserve the functions directly to the ICB board. One of the other proposals has been to establish a separate West Yorkshire level transformation committee, and we're still exploring the best way to transfer the governance functions, bearing in mind our commitment to reduce duplication and avoid over-bureaucratising decision making wherever we can. Whichever option we take, they'll both enable transparent decision making in public in the same way as the Joint Committee has done. And as I said, as part of the previous item, the risk currently overseen by the Joint Committee will be transferred to the ICB's Corporate Risk Register. So the Joint Committee is recommended to note the achievements of the Joint Committee and the arrangements for transitioning its functions to the West Yorkshire ICB.
Thank you, Stephen. And I think it's nice to see that summary. And I think one of the most important things as a committee I think we've seen over the last 4 to 5 years is people often wonder why I sit on these committees. And I think committees are there to make sure we can possibly do things once the West Yorkshire, do it effectively and act as enablers, but it doesn't happen without the people, you know, at the grassroots level delivering those care services. And as Stephen said, whilst we've had to make decisions corporately, I think some of the impact locally has been very obvious, and I think that's fantastic news. So any comments from that? It's nice to see. Any other comments from colleagues this morning on that paper? No? Okay, well, thank you for that, Stephen. And moving on to the final item, is there any other business from colleagues this morning? Ian Holmes, please.
Thanks, Marie. And you know, just before we wrap up, I just want to say a big thanks to you for the last 5 years. You've chaired the meeting. I think you've missed one for 5 years, and we really appreciate your input and leadership, and also the support that you've given Steve and myself and other members of the team. So I know you're part of the system in West Yorkshire at Swift, but just a huge thanks for the work that you've shown over the years, and lots of hands clapping there as well, which is really nice.
Oh, thank you for that. Quite emotional moment. Anyway, on behalf of myself to everybody, thank you very much indeed for the last 5 years. The committee's had a massive impact, I think, on many lives, and the decisions you've made and your contribution's been invaluable. So on behalf of myself to yourselves, thank you very much indeed. And I wish the Integrated Care Board all the very best for the future, and let's make sure our welfare and the people we serve in West Yorkshire continue to be served well, and we make improvements to healthcare at a local level for people. So on behalf of myself, everybody have a good day, and thank you very much for the final meeting of the committee. And I've handed over the integrated care system. Thank you very much indeed to everybody. Thank you.
Thanks, Marie. Thanks, Marie.